First will be taken up by Dr. Gopika, who's from MBR Cancer Center in Calicut, and she'll be discussing the ECHELON trial in Hodgkin's lymphoma, and we'll be having a short discussion of that, 15 minutes. And after that, 45 minutes. After that would be the presentation, and this will be a case presentation on lung cancer by Dr. Balaji. He's from RCC Trivandrum. We have our examiners. I hope they're online. Dr. Nikhil, who is assistant professor from Amrita Cochin, and we have Dr. Srilesh, who's a academician himself in AstroMIMS Calicut. So I think we'll start. I think our presenters are ready. We'll start with Dr. Gopika, the Journal Club, 15 minutes, and you can start sharing your slides now.
Hello, sir.
Yeah, you're audible, but could be a little bit louder.
Hello.
Yeah, much better, much better.
Good evening, all. Today I'll be presenting ECHELON-1 trial that's with brentuximab vedotin with chemotherapy for stage 2 or 3 classical Hodgkin's lymphoma.
Dr. Gopika, could you put it in full screen? We can see the split screen, the current slide. And okay, does it go bigger than this? Still showing within. Okay, no, that's. So this is in the presenter view. I think it's there right now. So for us, we are seeing the same thing that you're seeing as, you know, with the black background. Yeah, so if you could swap the view, the display settings, I think that might help.
Okay.
Yeah, here you can put the slideshow. Oh, could you swap the display setting and see if it works? If it works, we'll do it. Otherwise, yeah, from beginning. Yeah, display setting, swap presenter and slideshow. Yeah, it's coming as full screen visible. You can start now. Yeah.
Is it okay, sir?
Yeah, this is fine. Proceed.
So ECHELON trial, brentuximab vedotin. Patients with advanced classical Hodgkin's lymphoma are primarily treated with multi-agent chemotherapy, and the most common frontline regimen used is ABVD, and it results in a survival rate, progression-free survival of around 75%, but around 30% of patients have refractory disease or relapse after treatment with ABVD. And to account for this, more intensified regimens have been developed, but they are associated with improvement in efficacy, but at the same time, they have higher toxicities, both short-term and long-term toxicities. So they may be suitable for young and fit patients only. That's for patients with advanced stage Hodgkin's lymphoma. There is an unmet need for a treatment regime that can be used in patients of all ages that has a durable efficacy while avoiding the toxicities of bleomycin and escalated VCOP, and also avoiding the need for a change in therapy based on interim PET assessment. So we develop a target. CD30 is a characteristic surface antigen which is expressed on Reed-Sternberg cells in classic Hodgkin's lymphoma. So brentuximab vedotin is an antibody drug conjugate which is composed of an anti-CD30 monoclonal antibody. It is conjugated by a protease cleavable linker to the microtubule disrupting agent monomethyl auristatin E. But the current approved indications of brentuximab vedotin is classic Hodgkin's lymphoma after failure of autologous stem cell transplantation, or after 2 or more multi-agent chemo regimens in patients who are not candidates for transplantation, or after post-transplantation consolidation therapy for patients with Hodgkin's lymphoma who are at increased risk of relapse or progression. Coming to the mechanism of action of brentuximab vedotin. This is the anti-CD30 monoclonal antibody with the monomethyl auristatin E. The CD30 receptor binds to the receptor-mediated endocytosis occur, forms an endosome, then fuses with the lysosome, and monomethyl auristatin is released. It binds to the tubulin and disrupts the microtubule network and causes cell death. Now coming to the Echelon-1 trial design, it's an open-label, global, randomized phase 3 study comparing brentuximab vedotin plus AVD. It consists of a study was done across 218 sites across 21 countries, and at 2 arms. Patients were randomized. Around 1,334 patients were randomized equally into both arms. One arm is ABVD 6 cycles. The other arm consists of brentuximab vedotin. The dose is 1.2 milligram per kilogram IV infusions on day 1 and 15. Just cycle is alternated every 28 days. And the initial PET scan, screening PET scan is taken, and after 2 cycles, end of cycle 2 PET scan is taken. And also after end of treatment PET scan is taken. Then after that, follow-up was done either with CT or PET scan every 3 months for first 36 months, and then every 6 months until the study closure. Coming to the inclusion criteria. Age more than or equal to 18 years, histologically confirmed advanced classic Hodgkin's lymphoma, patients who had not been previously treated with systemic chemotherapy or radiotherapy, ECG performance status of 0, 1, and 2, and adequate hematological parameters, liver function and renal function. Exclusion criteria includes nodal lymphocyte predominant Hodgkin's lymphoma and those with peripheral sensory or motor neuropathy, non-cerebral or meningeal disease, or any evidence of residual disease from another cancer, or diagnosis of another cancer within 3 years before the first dose of chemotherapy, any clinically relevant cardiovascular conditions, or positive pregnancy test. Now coming to the primary endpoints, the primary endpoint was modified progression-free survival. It is defined as the time to disease progression, death, or modified progression. It is defined as the evidence of non-complete response after completion of frontline therapy. And the timing of the modified progression event was the date on which the first PET scan was obtained after the completion of frontline therapy, which is showing the absence of a complete response of chemotherapy. The secondary endpoint, the key secondary endpoint was overall survival. Other secondary endpoints are rates of complete remission, event-free survival, disease-free survival, overall response rate, and duration of response. And now this totally about 1,585 patients were assessed for eligibility, and of that 251 were excluded. Then 1,334 patients were randomized to 2 arms, 664 were allocated to brentuximab arm, and 670 to ABVD arm, and among that only 593 completed maximum number of cycles per protocol, and 608 completed maximum number of cycles per protocol in ABVD arm. Is coming to the baseline characteristics and disease characteristics and patient demographics. All the characters were equally balanced between 2 arms, that is brentuximab and ABVD arm, and the median age was around 36 in both arms. Most of the patients were more than 80% were below 60 years of age, and stage 4 account for about 64%. And IPS score more above 50% belong to IPS score of 2 to 3, and extranodal involvement was present in 60% of the patients, more above 60%, and end of cycle 2 treatment PET scan was negative in almost about more than 80 to 90% of patients. And an interim 3-year update, that's an interim analysis after 2 years was published, and it showed a progression-free survival benefit of about 5% absolute benefit in brentuximab vedotin and plus AVD arm. This is the 5-year updated data. showing ABD arm, brentuximab arm showing a progression-free survival of 82.2%, and in ABVD arm 75.3%. So statistically significant, p-value was significant, and it was there in PET negative patients also. The PFS was significant. In PET cycle 2, end of cycle 2, PET positive patients, and also there was a difference in increase in PFS, but it was not statistically significant, maybe due to less number of patients in PET positive arm. This is a log rank test, the same comparing the survival analysis between ABVD brentuximab arm and ABVD arm, and also in PET positive and PET negative arms. The p-value was significant in PET negative patient, but it was not statistically significant in PET positive patients. And this is the forest plot again, a subgroup analysis, which is shown in a forest plot, and most of the subgroup analysis favors the brentuximab arm, and the more consistent benefit was seen in age less than 60 years and North Americans, then stage 3, and also in male patients, and with more than or equal to 1 extranodal cycle. Now, after this 5-year updated data, now 6-year data updated analysis was abstract was published in ASCO 2022, and is showing an estimated 6-year overall survival benefit of 93.9% in brentuximab arm versus 89% in ABVD arm, which was statistically significant, and a PFS of 82% versus 74.5%. It was this across all the subgroups. This OS benefit was generally consistent with brentuximab vedotin, and the addition of brentuximab vedotin significantly reduced the risk of death by 41% versus the ABVD arm. And now comparing the both arms, the number of patients receiving subsequent therapy later after progression, more number of 24% in the ABVD arm needed subsequent anti-cancer therapy versus 20% in brentuximab arm. And among the treatments, majority of patients needed salvage next line chemotherapy, followed by radiation therapy, which was equally distributed in both the arms. And 2%, around 2% needed a transplant, high dose chemotherapy, and 7% and 9% needed high dose chemotherapy and transplant. Now coming to the death rates between the two arms, the total number of deaths were higher in the ABVD arm. It was lesser in the brentuximab vedotin arm, and most of the deaths were due to the complications of disease, progression of the disease or disease-related complications, while the number of second malignancies were less in brentuximab vedotin arm. Numerically, there were few second malignancy. It was around 23 in brentuximab arm versus 32 in ABVD arm. And coming to the toxicities, although the rate of febrile neutropenia was higher with brentuximab arm in the primary analysis, which was around 19% versus 8% in ABVD arm, it was also higher among patients more than 60 years, and also incidence of febrile neutropenia was higher in the earlier cycles than the later cycles. And primary prophylaxis with GCS reduced the rate of febrile neutropenia and also the rate of infections to a comparable level to that of ABVD. Now coming to the peripheral neuropathy, higher rates of, in the initial analysis after 2-year follow-up, peripheral neuropathy rate was higher with brentuximab vedotin. It was about 7% in brentuximab versus 43 in ABVD. But now after 6 years of follow-up, patients having ongoing peripheral neuropathy in brentuximab arm is 19% and 9% ABVD, and that too mostly grade 1 and 2 toxicities. Among most of the patients, around 86% in brentuximab arm, the toxicity is resolving or continuing to improve after 6 years of follow-up. And coming to the pregnancies, rate of pregnancies of fertility issues for brentuximab vedotin arm, 113 patients pregnancies were reported versus 78 in ABVD arm. No stillbirths were reported. And now coming to the relapses, most of the relapses in Hodgkin's lymphomas occurs early, that is with 12 to 18 months after treatment initiation, and most recurrences occur within first 5 years. Less than 5% of the patient who are disease free at 5 years will have a relapse by about 10 years. So in Echelon 1 trial, after since 3-year follow-up, only 6 relapses are recorded. So given the consistency of the PFS estimates with this trial and within the 5-year follow-up data now available, few additional relapses are being expected. Now coming to the conclusions in the updated analysis, that is 6-year follow-up, this ABVD, brentuximab vedotin plus ABVD arm significantly improved overall survival in patients with advanced classical Hodgkin's lymphoma, which was statistically significant. This benefit was improved in spite of the higher rate of subsequent therapy, that is anti-cancer therapy using ABVD arm. And it is also associated with fewer second malignancies, less progressive disease, and fewer disease-related death in brentuximab arm. So it is considered as a preferred first-line treatment option in patients with untreated stage 3 or 4 classic Hodgkin's lymphoma. Thank you.
Yeah, thank you, Gopika, for that presentation. If our examiners are here, Dr. Srilesh and Dr. Nikhil, any comments, any questions per se? Dr. Nikhil,
yeah. I think for a patient who is I think there's a lot of echoing. Somebody has to speak us. I think right now with the evidence that we have a alternative to what you say, bleomycin in patients who are not able to tolerate it. So I think brentuximab vedotin can be considered. I think till now only one patient I have tried that brentuximab vedotin along with AVD based on Echelon 1. There is a lot of other Echelon. We know the benefit in a relapse refractory setting as a single agent and also in combination with the bendamustine. And there's I think some trial also for nivolumab plus brentuximab vedotin. So this may be the new thing. Once it becomes a little more, I think the patent more generics come, we may be able to use it. But right now in our current setting, I still prefer. I mean, even though it shows a benefit in the Echelon 1 trial, maybe compared to ABVD, I would still stick to ABVD at the moment due to the financial toxicity also.
Okay, Dr. Srilesh, any comments?
Again, regarding brentuximab, my experience is also very limited. We have used it in one patient, that is basically in the relapse setting, but the dose is slightly different, if I remember, per kg, rather than the 1.2 that is used in this trial. That is every 3 weeks. So it's a well tolerable drug, but of course, since it is showing an OS benefit, I think we can consider it. But there are a lot of other issues like financial, as Dr. Nikhil rightly said, finances is the most important. The difference is very small, but since it is showing a survival benefit, I think it is a positive trial.
Okay, I'd like to ask Dr. Gopika, tomorrow, is there some, would you use this regimen come, the next patient you see with stage 3 Hodgkin's lymphoma, and this patient is around 65 years old, I think you've specified that there are certain subgroups. I think the NEGM trial also states there are certain subgroups that are going to be benefiting. So would you use it across the board or would you use it in that particular subset? This is the final question. Dr. Gopika.
Is that can be used in aged patients also?
Okay, did you happen to look at the editorial which accompanied this NEGM trial? And there was a commentary and the notes per se. And pulmonary toxicity, did you cover in this one? The rates of pulmonary toxicity, bleomycin versus this non-bleomycin therapy?
Yes, sir. Pulmonary toxicity is also mentioned there, but I haven't included that in slides.
Yeah, so that's, I think, a very important point, like when we also have the same thing in our journal club. So
Okay.
the important point we brought out was the pulmonary toxicity of bleomycin is something which we have seen quite terribly, and losing a patient with that is quite terrible. So this regimen could reduce the amount of pulmonary toxicity. So actually, I think the editorial or somewhere within the journal club, the journal itself, they've mentioned the rates of pulmonary toxicity. I forget exactly how much. So I think that's an important point to bring out when you're presenting like in a journal club. Like that's what we as consultants think about the toxicity. So the finances is there, but definitely I think that point about pulmonary toxicity, and always when you present the journal club, just have a look at the accompanying correspondence and the accompanying editorial. So you'll find many nuggets of information which will, add more substance to the journal club presentation. So I think that's one point where you can, add on to your journal club, get a more comprehensive picture. So other than the journal, the accompanying editorial and the correspondence that goes to them will also help. So just points regarding that presentation. Okay.
Yes, sir.
Thank you. Yeah, Gopika. And now we'll move on to Dr. Balaji, who's from RCC, and I believe he's a final year over there. And he will have the case presentations. We have Dr. Srilesh and Dr. Nikhil who will be the examiners. So the next 45 minutes, Dr. Balaji is all yours. You can start.
Shall I start, sir?
Yes.
Yeah. Good evening, one and all. So today I'll be proceeding with case presentation, which we encountered in our OPD practice. So coming on to the history, she is basically a 62-year female evaluated for fatigue and hemoptysis. So history of presenting complaint, patient was apparently normal before 2 months. Then she started developing fatigue along with the on and off blood tinged sputum. There is no history of breathing difficulty, chest pain, weight loss, or loss of appetite, backache, or headache. Past history, no history of diabetes mellitus, hypertension, coronary heart disease, hepatitis, or pulmonary tuberculosis in the past. Personal history, no history of cigarette smoking or alcohol consumption. Coming on to the family history, no family history of cancer, and menstrual history, she is postmenopausal for 17 years. Treatment history, no past history of medication. And coming on to examination, general examination, there is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or pedal edema. Vitals, heart rate was 90 per minute, which is regular in rhythm, and BP is 126/84, and respiratory rate is 16 per minute. Breast examination is within normal limit. Coming on to systemic examination, that is respiratory. Inspection, chest wall is symmetrical, moving equally with respiration. No dilated veins or visible mass. Palpation, chest wall is like the inspection finding has been confirmed with palpation. That is, the chest wall is symmetrical, moves equally with respiration. No mass palpable or tenderness. Coming on to percussion, resonant of both sides, there is no dullness. Auscultation, air entry is decreased in the left inframammary and infraaxillary region. Coming on to cardiovascular system, S1, S2 heard and no murmur. Abdominal examination, no hepatosplenomegaly and bowel sound present. Gynecological, no evidence of growth or bleeding per vaginum. Differential diagnosis could with this. First possibility is like malignancy of lung. Second could be tuberculosis. Third could be bronchiectasis. And fourth will be pulmonary arterial embolism. And fifth could be coagulopathy. So with this in mind, we further investigation has been done to the patient. Bronchoscopy has been done, which suggests of complete occlusion of lingular and infiltrative lesion in the left lower lobe. So with bronchoscopic guided biopsy from the lesion has been taken, which was suggestive of adenocarcinoma, lipidic pattern, napsin A positive. Molecular study has been done, which was suggestive of exon 19 mutation along with PDL1 expression of 20%. So this is the histopathological slide. The left one is the microscopic picture, these two. And this is the napsin positivity for the histopathology slide. And the down one is the TTF1 positivity of the same patient. So the patient has been like advised to undergo PET-CT scan. So which was suggestive of like 4.5 into 4.2 into 4 centimeters soft tissue mass in the superior basal segment of the lower lobe of left lung, SUV of 11. There is another lesion which is in continue with the above lesion involving the left hilar region with encasement of left pulmonary vein, SUV of 9. And there's mild ground glass area in the interstitial and septal thickening suggestive of lymphangitis carcinomatosis. Enlarged prevascular pre-aortic left paratracheal and aortopulmonary, which is the largest, measuring 1.9 into 1.5 centimeter, and subcarinal node. So this is the whole body PET-CT in 3D image. And this is the cut section, which is showing like, this is the CT image with the corresponding PET-CT image, which is showing intense FDG uptake. And this is the mediastinal section, which is showing that hilar node uptake. So coming patient has been subsequently underwent MRI brain, which was normal. And patient underwent mediastinoscopy and with lymph nodal sampling plus left pneumonectomy on 12th of January 2022 at outside hospital. During the procedure, mediastinoscopy has been done, which revealed enlarged carinal and paratracheal lymph node. So histopathology, which was suggestive of tumor size measure 5 centimeter in greater dimension, moderately differentiated adenocarcinoma, lymphovascular and perineural invasion present, visceral pleura is involved by the tumor, bronchial cut margin is positive, apex is 2 mm from the surgical resected margin tumor. Lymph nodal station, station 1, 4 node has been removed, which is none has a tumor. Unlike station 4R, 1 node has been removed, none of them is involved by the tumor. And station 4L, which show like 3 out of 3 nodes has been positive. Station 8 and 9, none of the node has been involved. So the final stage is PT2B N2 M0, which accounts for stage 3A. So after the excision, patient came to RCC for further management. Re-evaluation suggestive of adenocarcinoma of lung stage 3A. Hence planned for adjuvant chemoradiotherapy after a multidisciplinary tumor board meeting in view of positive margin. Patient received 4 cycles of adjuvant chemotherapy with paclitaxel in view of like logistic issue with accommodating for the 3D conformal radiotherapy planning. So hence patient received 4 cycles of paclitaxel carboplatin with the dose of paclitaxel being 175 mg per meter square, which account for 250 mg on day 1. And carboplatin AUC 5, the total dose being 500 mg on day 1, which is given every 3 weekly. So subsequently taken up for adjuvant radio chemotherapy to a dose of 60 mg, 60 gray in 30 fraction over 6 weeks with concurrent 5 cycle of carboplatin, which is given weekly, AUC of 2, that is total doses 210 mg. So patient tolerated the adjuvant treatment well. So this is the 4-field technique of 3D conformal radiotherapy, which has been done using a 4D CT technique, that is gating technique. And so further treatment of the patient, should we give osimertinib maintenance or atezolizumab maintenance, or just keep the patient on follow?
Shailesh sir, would you like to start or?
Yeah, Balaji, actually, what the intent of this presentation is basically is just like a DNB final exam presentation. But this looks like just a case, case history that you got, right, Nikhil?
Yes, sir. I
Can you
was just going to say that. Thank you, sir.
Basically, the idea of Ampok presentation is basically just to give the students an idea how the DM, how they actually present in the DM examination. Like a presentation in a meeting or something like that. that. So can you just,
Anyway, we will continue a discussion like how we will do a case.
yeah. Can you just go to the first page, first slide? Is it possible?
Yes, sir.
I would request people who are not presenting the case to or sharing the case to mute their phones. There's a lot of disturbance.
Nikhil, I think that's problem is from your side because the other way when only when you're speaking it's coming through.
Oh,
There's some issue there coming. The rest
I
of
can
it
just
is
rejoin on phone. Let me just try.
okay.
So basically, you will get a case like this as a long case. Sometimes you will get lung as a long case. So if a case like this comes in long case, just like your PG, I think the post MD days, when you present in the DM, I mean, when the final exam, the case should be like that only. You have to elaborate the presenting complaints, not like this. You have to elaborate the history of presenting illness, like little bit of details. You have mentioned everything, but it has to be like a case presentation.
Okay.
Especially if you are doing it for a DNB exam, you'll have it as a 30-minute case. For example, I'm a primary DNB, so I had a, malignant effusion, pleural effusion as my case, and it was a 30-minute discussion. So that should also include your history. I mean, if you finish your history, you can keep your DDs. You can keep your infective DDs. Of course, you can have a bias because we are an oncological patient is referred to. You can have a bias of that. Your history of presenting illness, what maximum you can do or additional points with your history, you can try to localize where is it a peripheral lesion or central lesion based on your history. That's a maximum you can do, and try to localize the so is it only respiratory or is there any metastatic symptomatology suggestive of metastatic disease? Is there any other features of a paraneoplastic disease? That is what would be the primary, maybe positive or negative history in a suspected. Either this patient is going to present you clinically as a pleural effusion. Of course, if we see a very stable pancreas tumor or something, it will be kept for the exam. And I think you will also have it as a short case. Well, history may not be that much elaborate, but you will have to get enough to get you clues into it and start your examination a proper way, at least the chief complaints. Again, in your examination, you need to be detailed your general physical examination, because it will be a short case for DM, and it will be a normal 30-minute case for DNBs. Your general physical examination should be thorough. In addition, that nutrition plays a very important role in the prognosis of a carcinoma lung. There are enough studies, I think, proving that it's a prognostic factor independent of this thing. And so you can mention the nutrition, your general physical examination. Obviously, there are a lot of paraneoplastic manifestation. You have, clubbing, your mechanism. The questions will go regarding the mechanisms of hypertrophic osteoarthropathy, etc. And if you're having features of SVC and all that, you will be expected to roll out. You have to describe it in detail. If you have a stable SVC, they might be kept. You have to describe the findings in detail. Shile sir.
Just like your MD or MBBS presentation in the examination, no difference. If you cut it very short, the questions will be more. So you have to actually extend the history and this physical findings so that we had to direct the examiner for asking questions. Like you said, so regarding this personal history, so what are the risk factors for lung, CL, what are the risk factors, common risk factors?
So cigarette smoking.
Yes.
And like passive smoking, like chullas, like they using like charcoal to burn and cook the food, like, and like occupational, like asbestosis can be there.
Yeah.
Anything else? Any other risk factors? What are the common other risk factors outside of smoke related, other environmental factors? From Kerala, especially one environmental factor we should be, especially RCC people should say, not very common in rest of India, but at least for Kerala, exposure to a particular agent.
Sir, radionuclide, like
Perfect. Good. Radon, especially, especially Kollam, that coastal belt. What are the what else when you have a patient with the cigarette smoking? What is the implication? Why do you need a detailed personal history in such patients, especially in a pulmonary case?
Sir, actually, cigarette smoking, like we have to calculate the pack years. So pack year has an important role. Like if patient is having more than 30 pack years and who is being currently smoking, quit smoking less than 15 years, it has a role in including the patients in lung cancer screening programs. And if the patient is currently smoking also, if you start the treatment, the outcome is detrimental. So one of the baseline, if patient is diagnosed with the CA lung, we have to, at the first setting, we have to counsel them regarding quitting the smoking, and we have to reinforce with every setting. So if the patient stop the smoking, then the outcome is better than patient who continue smoking with our concurrent treatment. And if the patient who has quit the smoking 10 years before, then the mortality level decreased to 50% as compared to that a patient who is currently smoking with the CA lung. So these are the few benefit patient might get with quitting the smoking.
What is the benefit generally? What is the benefit? What is the risk reduction in a patient who has stopped smoking for more than 15 years?
So it is equivalent to normal population, sir, if it is more than 15 years.
Very good. I would be careful. It is not equivalent, but it reaches 80 to 90%. So risk reduction, that means almost close to the normal population, but a former smoker is never equal to a never smoker.
So regarding smoking, you said one is it is important for the etiopathogenesis, right? So second is second is you said if the patient continues to smoke during our treatment, it is detrimental. So any other implication smoking and lung cancer regarding histology, regarding treatment with this particular agent, regarding the mutations that these patients can get, any other implications?
Mutation will be less, sir. If patient is smoking, then the mutation, driver mutation will be less, I guess. And the tumor mutation can be more, I guess.
If this patient is fortunately a non-smoker, suppose if a smoker comes and the examiner asks regarding smoking, first they will ask about what is the definition of a never smoker, what is light smoker. There are certain definitions, even though it is not standard, you will get NCCN. Never smoker means never smoked or less than 100 cigarettes per lifetime. That is the definition. So you have to read that definition. Then you have to read the mechanism. How does this smoking causes lung cancer? So you have to know the various hydrocarbons or aromatic and nitrosamines. You have to know about the carcinogens, etc. Then regarding this treatment wise, you said this is ongoing smoking is also the detrimental effect. Then third thing is actually the smokers are more likely to get which mutation? KRAS mutation. They are more likely to get KRAS. They will have many mutations, but not the usual targetable like EGFR ALK. So usually that is seen in non-smokers, right? So basically they will have high mutation rate. So because of the high mutation rate, there will be more sensitivity to what treatment in lung cancer, like is it targeted immunotherapy? Which one will be more working in smokers? Basically immunotherapy, basically in lung cancer, they will have a lot of mutation, they will have a lot of neoantigens. So they will, the response to immunotherapy will be more in patients with smokers. So there are even some trials which are done exclusively in smokers, immunotherapy trials. So when you are asked about smoking, you have to know from basics to maximum, from the treatment purpose also, from the till the treatment.
Okay.
Okay. What are the other risk factors? Indoor air pollution, females, especially good indoor air pollution is a important risk factor. So if someone asks You have to tell that also. Familial risk in lung cancer. Is there any familial?
Sir?
Familial family history, is it important in lung cancer? Family history.
Degree relative cancer, then the patient will have high risk of like carcinoma of lung. First degree relative cancer and first degree relative.
There are some association, but there is not specific genetic like breast and ovarian. It is not a, there is no specific mutation, but it is found that there is some genome-wide association studies have shown that there is, it is some familial component associated with some environment. You have to say like that. Okay. Then occupational history is very important in lung cancer, especially if you are presenting, especially males, you have to specifically say regarding occupational history. Especially like you said, asbestos, what is the risk? What are the malignancy that can be associated with asbestos classically?
Mesothelioma.
Yeah, then lung cancer. Okay, next page, next slide. So again, in general examination, when you are presenting an oncology case, you have to say the ECOG performance status. That is very important when you present a oncological case. You have to first you should be ECOG performance. That is very important in oncology, right?
Yes,
Next. So next.
So what are the clinical scenarios you are expecting in if a lung carcinoma case is kept for you? Mostly the patient will either it will be a consultation presentation, right? Or it will be most commonly what you're getting is pleural effusion. Or SVCs and all may not be stable enough to sit for the exam. Okay.
Again, this gynecological examination, you said no evidence of growth. That is a broad, vague term. So actually, where exactly is the growth? You have to mention, if you are mentioning gynecological examination, you have to mention it properly. You cannot say no evidence of growth. Is it in the, where exactly is the growth? So that also vulva, is it in the vagina? Is it in the cervix? So examiner may get a wrong idea. So you don't put like this because sometimes you just gynecological examination normal. They won't even ask in examinations. And regarding differential diagnosis, bronchiectasis coagulopathy. Why you said it is coagulopathy? Hemoptysis.
one of the last.
Coagulopathy is not a diagnosis. It's not at all a differential diagnosis. It is a complication of some diagnosis. So you can never say like coagulopathy. In pulmonary artery embolism, patient will not present like 2 months history. So before mentioning this kind of thing, just most of the time they will be asking like what are the oncological causes of the same.
Okay, sir.
Yeah. So suppose you reach here and next question will be how will you proceed? So you have certain differential diagnosis like lung mass or effusion or whatever. So how will you proceed?
The baseline laboratory investigation I would like to perform, sir, like a complete blood count with liver function, renal function with serum electrolyte levels.
Why you want to do all this?
The patient is having like hemoptysis, so hemoglobin level might go down. So
Very good. Yeah.
and like apart from malignancy, like other bleeding manifestation could be there. So we have to rule out the cause for any thrombocytopenia as there.
Excellent. Yeah.
And like if patient is like having like a pneumonia, like other like related other infection, then the WBC count could help us in like ruling out any infection also.
Okay.
Differential count.
Okay.
So coming on to the liver function test, like if the carcinoma of lung with liver metastasis, then the liver function abnormality could be there. And like if it is elevated, then the further treatment could be like modified because of that altered baseline liver function.
Okay.
So we can.
You need all this baseline investigation for planning your treatment, right? So one is that, like you said. Then again, metastasis. High alkaline forces you will get even in bone metastasis.
Yes, sir.
Then what is the importance of RFT?
So renal function test also like patient like baseline is needed. Like we cannot give certain chemotherapy if the creatinine level is high.
Before that, we have not reached the chemotherapy. You have to do a definitely CT scan. You have to do a contrast CT scan. Sometimes patient can have hypercalcemia, can cause renal failure.
Renal
So you
failure.
have to say like that. Sometimes patient might have taken some anti-inflammatory analgesics. That may be the cause. Rather than treatment, you have to do a CT scan, right? Contrast CT scan. So for that also, you need a renal function. Calcium you have to do. Sodium. Why you want to do a sodium in lung cancer?
Sir, SIADH is common. Sir. Syndrome of
Which type of
inoperable
lung cancer you say?
small cell lung cancer is more common.
Which one?
Small cell,
SIADH?
small cell.
Yeah. Okay. So next investigation, what will you do? Suppose patient comes to your OPD, which investigation you do? You said you directly bronchoscopy. You did directly bronchoscopy, right? So what is the apart from the blood investigation?
Chest X-ray, like baseline chest X-ray could be done. That should be the baseline. Like that will give some idea from which lobe of the which side of the lung it is arising and which like part of the lung, whether the central part or the peripheral part is like affected.
Why you want to do that?
So,
Why you want to know that whether it is central or peripheral?
sir, like further, like that will help in if it is central, then bronchoscopy will help in fetching up the thing. And if it is periphery, then like the diagnostic modality, like guided, like any tissue diagnosis can be guided by like transthoracic approach. So that is one of the reason we want to know which part of the like lung the mass or the lesion is arising.
Nikhil, you proceed. Nikhil.
Yes. And what else? Okay, you've taken the chest X-ray. You're finding, and collapse consolidation, and also what seems to be a mass on the, peripheral zone of a left side. How do you proceed? How do you for the project? You've done all the blood investigations as you have already mentioned. All are within normal limits. You have taken your X-ray, and the patient has come back with the X-ray film to you. You have found a collapse mass along with a collapse present.
So
What would you do next?
next, I will would like to proceed with the like a better imaging modality, which could be in the form of like a contrast enhanced CT or like a high resolution CT scan, sir.
Okay.
Which will fetch us more detail, like what is the nature of the lesion and where it is exactly located.
Okay. And then based on that, how would you like to proceed further? You got a CT scan, you have localized the disease. How else would you like to now proceed?
Sir, if it is like we will like to, I would like to know only the lesion is there or any mediastinal node is there also. Significant image wise enlarged mediastinal node. Depending upon that, if it is like a like central lesion with enlarged mediastinal node, I would like to proceed with the flexible bronchoscopy and to take a tissue diagnosis along with the endobronchial ultrasound guided a needle FNA from the enlarged node. So so depending upon the result, then if the tissue diagnosis and the mediastinal lymph node is positive, then like if it is N2 and like if the lesion is like carcinoma of lung, then I would prefer to proceed. I would like to chase the patient first. Like,
What is N2 that you bought it up? What is N2, N1, N2, N3?
sir, N1. N1 is like the node peribronchiolar and peribronchiolar node and is the N1 and N2 will be like ipsilateral hilar and ipsilateral mediastinal ipsilateral mediastinal with subcarinal node will be N2. N3 will be like
Is it
N1.
N1, it will all come in N1, no? Along with the whatever is localized to the lung intrapulmonary node, your peribronchial, your hilar, ipsilateral will all be N1. Then N2 goes to the mediastinal, right? Ipsilateral.
And sir, contralateral mediastinal node will be N3, sir, and ipsilateral scalene and supraclavicular and contralateral scalene and supraclavicular will be N3.
Okay.
So So with the tissue diagnosis, I want to properly stage the patient clinically. So whether it is like metastatic or non-metastatic. So that will be my next intern. So if the patient is turned out to be non-metastatic, and if it is like localized disease, locally advanced, or if I want to know whether it is early stage or locally advanced. So so I would like to classify the patient whether it is early disease or like locally advanced. So the treatment modality will be changing depending upon the stage of the patient also. So like with the tissue diagnosis, I would also like to know the mutational status and the PDL1 status of the tumor also, which could guide us in further treatment of the patient.
In your tissue diagnosis, you are getting a poorly differentiated carcinoma.
Okay, sir.
Okay. Would you like to further, you are in a setup where, you have to guide the pathologist. What would further would you like to do?
Sir,
What
like
else would you like to look at?
three marker I would like pathologist like P40 to rule out squamous histology, napsin A or TTF1 to rule out adenocarcinoma of lung.
Very good. What just for completion sake, what happens to the cytokeratins? Will cytokeratins also is there a different
Yes, sir.
differential cytokeratin? Is there a difference?
It's a CK7 will be positive for adenocarcinoma, CK20 will be negative for adenocarcinoma, sir.
And what about any other CK will be positive for squamous? Maybe 60-70% of squamous. CK5, 6 for squamous. The other markers, just for completion sake, your P63 for squamous, and as you already mentioned, your NAPS and TTF1. Okay. You were mentioning something about you would like to further differentiate the patient. I will come to the further workup of the tissue or the further diagnostics on the tissue, but what further investigation and evaluation would you like to do? You told you want to differentiate between early and extensive disease. Am I right? You want to differentiate like that?
Yes, sir. Like whether it is like early stage, like
what I'm asking is what is the role of PET-CT in such a patient?
Okay, sir.
Patient has on your CT scan, he is having one hilar enlarged 1.15 mm hilar node, one mediastinal 1 centimeter mediastinal node ipsilateral, and he has a lesion. You're seeing the lesion in the hilar area, which you have already taken a bronchoscopic guided biopsy, and you also evaluated the nodes by your EBUS.
Sir, actually, there are like 4 category of like patient can fall into like mediastinal involvement can be categorized into 4 categories, sir. One is like direct at group A will be like patient who has the lesion directly involving the mediastinum, which is clear cut. In that there is no role of PET-CT. And second comes the patient who is having a lesion along with the enlarged mediastinal lymph node, which is like more than 1 centimeter in the axial cut. So they will be categorized as group B. And group C will be like central or like peripheral lesion with peribronchial or like intraparenchymal node without enlarged mediastinal node. They will be falling into group C. And group D will be like peripheral like a lesion without any mediastinal uptake. So they are like group D. So in group A, there is no role of PET-CT. But definitely in group B and group C, there is a role of PET-CT, which could help us in like narrowing out whether the lymph node is involved or not. In spite of that, if the patient, if you're doing in group B or group C, PET-CT is showing uptake. Still, I would like to, I would prefer to go ahead with the tissue diagnosis because the sensitivity of PET-CT is only 80% and the specificity is around 80%. Still, there is a chance of 20% false positive and false negativity.
Very good. Very good.
And coming on to the group C, so the sensitivity of detecting by the CT scan itself, like it is 90%. So if we add PET-CT to that, the sensitivity will be rising up to 97%. So in such patient, if like PET-CT is negative, definitely the mediastinum is like clear of tumor. So we can safely proceed with the treatment. So in group D of a group of patients. So
Okay.
You have a 5 centimeter peripheral lung tumor.
Nice, sir.
5 centimeter lung tumor.
So,
CT.
monitoring pulmonary nodule.
Nodes.
Sir?
5 centimeter tumor. CT guided biopsy shows adenocarcinoma. Mediastinal nodes are not there in the CT scan.
Okay.
Patient fit. What will you do?
Sir, I
Nothing
would,
else.
sir, 5 centimeter peripheral lesion without any enlarged node in your
In the CT scan. In the CT scan. Will you do a PET CT for this patient?
Sir, like, sir, I would prefer to go with like mediastinal evaluation with mediastinoscopy rather than PET CT.
So you say you are saying that sometimes you have taken only the CT chest, right?
Yeah, sir. Yeah.
So this lung cancer is not going through like first in the hilar node. It can actually throw metastasis elsewhere, right?
Yes, sir. Yes, sir. Definitely, sir.
So actually, for saturation, you have to take a full staging, right?
That's what sir, I said, like, I would like to do a full staging for the patient. Like,
With what?
like CECT, chest, neck, abdomen, and pelvis with bone scan and MRI could be one of the option. So other option will be like simple one go will be like PET CT.
Okay. In your center, which one you prefer actually? Is it CT scan or is it PET scan?
Sir, like,
What you said is correct. What you said is correct, but local practices.
sir, instead of exposing the patient to multiple imaging modality, if patient is affordable, I would like suggest patient to go ahead with PET CT.
Okay, okay. Suppose the patient has got a hilar node, a peripheral lung lesion.
Yes,
Then
yes.
what will you do? Adenocarcinoma lung, peripheral 5 centimeter lesion. There is a small hilar node on the PET scan. No lesion elsewhere.
So PET scan uptake is there, sir.
Yeah, PET scan hilar node uptake is there.
So it is like patient will be falling into stage 2B.
Okay, then what will you do?
Sir, like if upfront, I will like to discuss the patient details with the surgeon, whether thoracic surgeon is like planning for upfront lobectomy like for this patient if it is non-metastatic, and if the surgeon
What additional investigation you plan apart from PET scan before you are considering a surgery in a lung cancer?
pulmonary based in pulmonary function test and like cardiology evaluation has to be two things.
Why you want to do that? Why you want to do that?
The post lobectomy expiratory capacity is important.
Very good.
Because the mortality would be increased with patient who has like impaired baseline pulmonary function test.
Okay, there are certain values for lobectomy. There are certain values for pneumonectomy that you had. Apart from that, apart from the fitness, any other imaging modality you will do before patient is you are sending for surgery?
Imaging modality. Diffusion capacity, sir. Pulmonary diffusion capacity.
Okay, that's fine. That's for the fitness workup. You said in this presentation, you had done an MRI brain. Before you send the patient, even if you take a PET CT, you had to take an MRI brain. Why?
Sir, because PET CT, the uptake, the FDG uptake of the brain will be more, sir. We cannot differentiate the minute small lesions, sir. So lung cancer account for 75% of the brain metastasis which we encounter in the oncology practice. So even if the tiny brain, like already pointed out, without involving the mediastinum, a patient can have direct brain mets also. So
again, the sensitivity to detect brain metastasis in the that you have to tell like that. Sensitivity to detect brain metastasis may not be high. So if you are planning for a surgery or a chemoradiation, you have to always look for MRI brain. If PET CT is not enough. Again, if the MRI brain is not possible, you have to do a CT contrast, CCT brain plus contrast. And what about in the metastatic setting? Is it indicated in asymptomatic patient? MRI brain, is it indicated?
Sir, you are saying like if the patient is found to have brain mets in PET CT, it is
No, no brain medicine PET CT patient has got a stage 4. Same this patient.
okay.
This patient is an EGFR pure positive, EGFR positive, like EGFR positive stage 3. Suppose it is a stage 4. Patient has got an adrenal metastasis. It is an EGFR exon 19 deletion positive disease. Will you do an MRI brain?
Yes, sir, obviously I would like to do it because like we to assess the further treatment response, we want a complete staging, sir. If the staging is incomplete, like if the patient like during the course of treatment developed any CNS symptom, we cannot like be sure whether the patient had brain lesion which has progressed or it is a new lesion which has progressed. The patient had new lesion, so I would like to have
So
MRI.
in the recommendation wise, guideline wise, you have to do an MRI brain. Nowadays, it is all patients, even for even mutation negative patients, you have to consider for an MRI brain, right? And again, your therapeutic approaches will differ. In MRI brain positive brain metastasis, you will like to choose a particular TK rather than another particular TK. So that is the second important point. Especially, and third important thing is that these EGFR mutation positive patients has got a high tendency to have brain metastasis. Right. Yeah. Nikhil, you can just.
Yes, I think we have covered most of the workup part of it. What are the common assays you will send for if this same patient is metastatic? What all workup would you send for? On a patient now he's non-metastatic, you operated on him. What all are the workup or what further investigation would you do on a this patient has been operated upon, right? He's a T2N2, right?
Yes, sir. T2
So
and
what further evaluation would you do on your post-op specimen?
further evaluation, sir.
Yeah, on your post-op histopath.
Sir, molecular study has to be done like in a complete specimen, like apart from EGFR, any other mutation is there in the like the completely excised specimen.
Okay. Any role for any other other than EGFR mutation? Is there any role for any other thing in adjuvant setting? Any other targeted therapy in the adjuvant setting?
Sir, atezolizumab like adjuvant, PDL1 expression.
Yeah, PDL1 is just done by molecular testing. What is the method for PDL1?
Sir, in atezolizumab, like SP 142, sir, for atezolizumab.
Okay, SP140 antigen.
What is it?
What is it?
Molecular test. How will you do a PDL1 testing? Is it by NGS? Is it by a sequencing, or is it by any other some
IC, that is combined positive score, sir. Like CPS score is there. ISC, we will be doing. It's like combined positive score, sir. It is like number of tumor cells which is expressing the PDL1 along with the like immune cells, that is like lymphocyte plus macrophage divided by the viable tumor cells into 100. So it is by ISC.
So you will get a question if you end up on IHC about PDL1, you will get in lung. What is it? Are we looking at the CPS as you mentioned, combined positive score, or are we looking at something else?
Sir, we are looking for TPS, sir, tumor proportion score, sir, which is like the only the tumor cell expressing the PDL1 divided by the viable tumor cells into 100, sir. We are excluding the immune part of the into the calculation.
Okay. And how would you actually manage this patient? Forget about what actually happened to this patient. Right now, you have done this test.
Yes,
There
sir.
is no EGFR. There's no EGFR mutations. There's no mutations or deletions seen. There is, I think PDL1 for discussion purpose, let us say less than 1%.
Yes, sir.
How would you manage this patient?
So, sir, yeah, I want to.
She is a fit lady. She is a fit lady.
Sir, I would like if it is
Good recovery post-op.
Sir. So post-op, you are saying, sir, like
Yeah, post-op. Or say this scenario.
Okay, sir.
Patient in whom we have underwent a pneumonectomy. She has recovered from the rigors of the surgery,
Yes, sir.
and the post-op specimen has no mutations, no significant, no targetable mutations. PDL1 negative, I can say. How would you manage?
Sir, if with the being positive
Margin negative. For discussion sake, we'll keep it as margin negative.
Okay, sir. Margin negative and all the mutations are negative and stage 3, I would like to offer the patient fit patient like adjuvant 6 cycle of chemotherapy, that is with like cisplatin plus pemetrexate based because adenocarcinoma.
Why the cisplatin? Why are you insisting on cisplatin? Is patient is just recovering from a major surgery, carboplatin may be less toxic. Is there any benefit? Is there anything to suggest a benefit, evidence to suggest a benefit of cisplatin in the setting?
Cisplatin, like I'm not able to quote the data, but there is a like cisplatin has an upper hand over the carboplatin. Like
Very good. There's a meta-analysis also where the hazard ratio is around 0.89 LACE. It is called LACE.
lace meta-analysis.
And most of other trials also have included, all your chemo trials have included cisplatin only. Of course, we end up using carboplatin, some of this patient for whatever benefit it is, that's okay. If this is it was a T2N0 disease, would you consider the chemotherapy still?
So I want to look into the
Post-op.
like size of the tumor, sir. If it is less than 4 centimeter or more than 4 centimeter. So if it is less than 4 centimeter, I would rather keep the patient on like follow-up. If it is more than or equal to 4 centimeter, then like I would like to give the adjuvant chemotherapy because we can consider the patient as a high risk patient, and like I would like to offer like with the adjuvant chemotherapy benefit.
So T2N0, we consider some risk factors, and high risk patients, we offer them adjuvant therapy. What are the other high risk? You mentioned size, very good, more than 5 centimeter. I mean, more than 4 centimeters. Okay.
And
What are the other high risk features?
Extent of surgery, whether wedge resection patient underwent or like lobar, like sublobar resection or lobectomy. So surgical excision is also important, like extent of surgery.
Extent of surgery is very good. I think LVI is also a factor. And of course, a poorly differentiated malignancy becomes a major factor.
Yes, sir.
Regarding number of cycles, adjuvant, will you give 6 or 4? The data is, I think it is only for 4.
4.
It's not enough, I think.
4.
6 is not needed. I
All
think
of
only
them, even the pemetrexate cisplatin trial, the ANITA, that is vinorelbine, platinum, all are 4 cycles.
Okay.
I think so.
I think the time is almost over, right, Arun? Arun, why is there? I think one last question. So this particular patient actually presented in a metastatic setting.
5
So you
minutes.
do all the molecular testing. It is a stage for adenocarcinoma, female patient. You have EGFR, exon 19 is positive. The other mutations are negative, and this PDL1 is 100%. What will you do? You got my question right?
Yeah, both EGFR 90.
For exon 19 is positive and the PDL1 is 100%. What will be your regimen?
Sir, you are asking whether I will prefer osimertinib or single agent pembrolizumab. You are asking, sir.
Yes.
I would like to put the patient on like osimertinib.
Why?
Sir, if patient progress on osimertinib, still we have the option of pembrolizumab. Actually,
The second line.
second.
Basically, the dictum is that the most important thing to consider is actually your molecular studies. EGFR most patients, even if the PDL1 is 100%, you have to use the targeted agent first. That's why in smoking, what happens is that you will have more and more mutations, neoantigens. So they will be more likely to have this response to immunotherapy. But the EGFR positives are basically, they will have less neoantigens. So their actually response to immunotherapy is less. So basically, that's just even in the second line, I think it is you should be chemotherapy rather than saying immunotherapy. Even if it is 100%, you have to say like either a chemotherapy or a regimen containing chemotherapy. Like ABCP, there is another regimen known as ABCP, which will work in these mutated patients. I think it is almost 8:30, right, Balaji? I think Dr. Arun.
Yeah. So yeah, I think it's time. It's enough grilling for one session. I think it went wonderfully well, as Dr. Nikhil also. Thank you.
Dojo farmer.
Yes. I'll hand it over. Yeah, Dr. Bobbin is here. So sir wasn't there at the
Yeah.
beginning, so I'll hand over to sir.
Yeah, sorry that I joined a bit late, but then it was good discussion we had today. The case presentation, as you mentioned, it went like an academic, it went like a, what do you call, not like an exam case, but then you people managed it very well. You just came back and then went step by step in a very, very, what do you call, very proper examination kind of a way. So all the the presentation as well as the case presentation, both you did, both the postgraduates did very good, and I would like to congratulate both the examiners also. So, and it's good that we had more than 60 participants were there, and almost everybody stayed back till the end. So that shows that the quality of the discussion was also very good. So congratulations everybody, and thank everyone for the initiative. So thank you. Over to you.
Oh, thank you, sir, so much. Actually, sir's initiative is there. So, anyway, good. I think we've there's stuff for all of us to learn. Even I also learned some new things. So I think, just because we're past the student phase, we should not ignore it. We should forever remain students. So I learned something new from this discussion. So we did quite well. As we said, even after you pass out, after you practice in life, you have to keep learning. So you keep learning new things. Okay, thank you all. And we'll discuss the next case, which will be present over the next 1 week. We'll have it next month, again, the last Thursday of the month. Thank you all for joining. Take care and good night.
Bye. Good night, everybody.
Night, good night.